I'm a critical care physician at the University of Toronto, and I have an interest in oncologic critical care, and in particular, critical care of patients with haematologic malignancies. With regard to disclosures, the only relevant disclosure is that some of the data that I'll be presenting is data that was supported by the Leukemia and Lymphoma Society of Canada from a grant that I obtained with one of my colleagues, Dr. Geetha Mehta. Now, many of you may recall a time period when there was a lot of historic pessimism surrounding candidacy for ICU admission across patients with hematologic malignancies. But due to advancements in critical care management, oncology care, and infectious disease practices, we've seen a significant improvement in critical care mortality over the years across all subtypes of cancer, as well as some subtypes of hematologic malignancy. Now, this is not just limited to the fact that we've potentially decrease the threshold for ICU admission for certain patients with cancer. This mortality decrease has been seen irrespective of intensity of organ support, which was demonstrated very beautifully in this very large Brazilian observational study that was published last year that demonstrated decrease in mortality over the past few decades, irrespective of organ support received. So this historic pessimism surrounding candidacy is outdated. I will acknowledge that heme malignancy mortality is higher than the general population and solid tumor population. However, now I feel like we can start to focus our attention more on contemporary data surrounding incidence of critical illness, the critical care conditions that present themselves, who should be coming to the ICU, and even long-term outcomes. And over the next few minutes, I'm going to provide a brief overview of some contemporary data on these topics. So to evaluate the incidence of critical illness, myself and my colleague, Dr. Bruno Ferrero, we conducted a population-based cohort study with colleagues in Toronto. And looking at population-based data in the province of Ontario, approximately 14% of patients with hematologic malignancy were admitted to the ICU within 1 year of diagnoses. And not surprisingly, incidence varied based upon malignancy subtype, with some, like acute myeloid leukemic patients, having a higher likelihood of requiring ICU admission within 1 year following diagnosis. Now, when I reflect upon critical care conditions across patients with hematologic malignancies coming to the ICU, I like to divide them into disease-associated critical illness and treatment-associated critical illness. And obviously, I'm not going to review this in depth, but I do want to highlight that respiratory failure and sepsis continue to be the most common causes of ICU admission. Increasingly in the future, we may see more treatment-associated toxicities, such as those from CAR T-cell therapy, as indications for CAR T-cell therapy expand. And Dr. Mateksa in the next presentation will expand on this in greater detail. Now, importantly, there are some very specific causes of critical illness that are associated with hematologic conditions. And this is outlined in our paper that was led by Dr. Jenna Spring. And in this paper, we highlight AML emergencies, neutropenic sepsis, SVC syndrome, hyperviscosity syndrome, as well as complications following stem cell transplant. But there are two things I wanted to highlight are important in considering your history of patients with hematologic malignancies that develop critical illness. And the first is that it's important to understand the phase of treatment that they're in. On their journey from diagnosis to outcome, whether it be cure, sustained cancer control, or end of life, there are many time points at which these patients may develop critical illness and may warrant admission to an ICU. It could be at presentation, during induction, or peak of treatment-associated immunosuppression, and these are associated with distinctly different causes of critical illness. Now, the second is that it's important to really understand the mechanism of immunosuppression of this patient population, whether it's driven by the disease or the treatment, because this changes your differential as to what the infectious agent may be if the cause of critical illness is driven by infection. And a nice summary of this is highlighted in one of Dr. Ali Azalei's papers that was published in Lancet Respiratory Medicine from 2018. So now that we have this shift in our perspective surrounding candidacy, I will acknowledge once again that there are a subset of patients with hematologic malignancy who continue to do poorly in the setting of critical illness. So who should we be offering ICU to in this population? When we look at contemporary data surrounding sepsis and septic shock outcomes, A recent cohort study by Dr. Lemieli from Paris evaluated approximately 2,000 patients with cancer and sepsis and looked at changes in mortality over time. The graph on the left shows outcomes across patients with solid tumor with sepsis, and the graph on the right, outcomes of patients with hematologic malignancy and sepsis. And when we look at their 30-day mortality, their in-hospital mortality is approximately 30%. Now, acute respiratory failure prognosis has also markedly improved, but still remains high and higher than the non-cancer cohort, as was nicely demonstrated in a secondary analysis of the LungSafe database, looking at a lower likelihood of survival in immunocompromised patients compared to non-immunocompromised patients. And this is obviously also true across ARDS for patients with malignancies. Mortality remains 50 to 60% consistently across observational studies in this patient population. When we look to observational studies of consistent factors associated with mortality, comorbid conditions, poor functional and frailty status, treatment refractory graft versus host disease in allogeneic stem cell transplant patients, the need for invasive mechanical ventilation, but in particular, invasive fungal infections, a number of organs failed continue to be associated with mortality across many studies. And interestingly, subtype of malignancy is not associated with in-hospital and ICU mortality when you adjust for severity of illness factors. So when I reflect upon who should be coming to the ICU for each heme malignancy consult that I have, and I reflect upon the potential utility of ICU admission, I tend to ask myself, well, what is the critical care condition and associated prognosis? What is the patient-centered objective of this ICU admission? But also, what is the long-term oncologic prognosis without critical illness? What are their treatment options? Have they received them? Will critical illness impact this? And how will critical illness impact this? And a lot of these questions I can't actually answer without the involvement of an oncologist. But I will add, there's some questions where we really do have limited data. So finally, given the improving ICU mortality rates, what happens after the ICU? And unfortunately, there is a paucity of data in this space. Myself and my colleague, Dr. Geeta Mehta, here in Toronto, we just completed our critical care outcomes observational study of hem-onc patients in Canada across 8 ICUs, the results of which we're presenting at our Canadian conference next week, but I thought I would just give you a snapshot of this. Across 400 patients admitted to 8 Canadian ICUs, most had high-risk heme malignancies such as acute leukemia. We had a very high proportion of stem cell transplant patients. Most were admitted with respiratory failure. About half required invasive mechanical ventilation. The ICU survival of this cohort, which was a higher risk cohort, was about 53%, and only 37% of those survivors survived to 12 months, which was 20% of the original cohort. And the lower survival compared to other cohort studies is likely driven once again by the high frequency of high-risk hematologic malignancies. But we also looked at treatment post-ICU at 7 days, 6 months, and 12 months, and we classified patients as having treatment continued as the same treatment plan pre-ICU, whether there was a change in treatment such as a dose reduction, medication change, or no longer a candidate, or no treatments were indicated at that time. And as you can see here at those time points, a large subset had a modification to their treatment regimen. So when we reflect upon the hypotheses for these long-term outcomes in our high-risk hem-onc cohort post-ICU, it could be possibly due to critical illness manipulating or modulating the effectiveness of the anti-cancer treatment that was received pre-ICU, decreasing the likelihood of remission. Critical illness potentially affecting people's candidacy for ongoing treatment, whether it's due to accumulated frailty or organ failure, or maybe those that are predisposed to develop critical illness or those that are predisposed to have a poor long-term outcome anyway. So we have multiple more analyses that are underway to try to better understand those questions. So in conclusion, the incidence of critical illness is not uncommon in the hem-onc population with a higher likelihood across certain higher risk subsets. ICU mortality has improved significantly over the years, so now we need to more meticulously think about longer term outcomes. Critical illness may develop as a consequence of definitive treatment for hematologic malignancy, which may be administered with curative intent. There are lots of unusual disease processes that can complicate treatment. The etiology is not always easily identified. And when we reflect upon the goals of the ICU admission, it may be more than just trying to bridge an individual to survival with an acceptable quality of life. There's the added complexity to bridging them to ongoing treatment. There are many areas of uncertainty that remain, such as how critical care conditions may be different pathophysiologically in hem-onc versus non-hem-onc patients, whether evidence-based ICU management principles are generalizable to this population. And we certainly need a more granular understanding of drivers of poor long-term outcomes across this cohort.